We're going to talk about Chapter 17, Labor and Birth Complications. So when we talk about preterm labor and birth, I want to talk about a few definitions, because this is where we start to talk about weeks and what defines preterm versus postterm versus late preterm versus preterm labor versus preterm birth. So let's go over a couple of definitions from your textbook. I just want to define that preterm labor is cervical changes and uterine contractions that occur between 20 and 37 weeks. So 20 to 37 weeks is considered preterm labor. Then we have preterm birth. So this is any birth that occurs before the completion of 37 weeks. So preterm birth before the completion of 37 weeks gestation. The other thing I want to talk about is late preterm and what they consider, they define further. If it's a late preterm baby or birth, that baby is born between 34 to 36 weeks gestation. You do have some other terms where they talk about the difference between preterm birth or maturity and low birth weight. Sometimes they tend to use this interchangeable when they talk about it. When we talk about someone who is a low birth weight, we're talking about the actual weight at the time of birth. So if they're a low birth weight baby, they are less than 250 grams. And remember, when we talk about babies and birth weight, macrosomy versus low birth weight, they always talk about baby's weight in grams. So your 2,500 grams is actually 5.5 pounds. So this is a little teeny one, and they're super cute when they are that teeny. But don't get me wrong, my favorite are the big fat chunky babies with chunky cheeks. So that's kind of a definition as far as low birth weight goes. And remember, low birth weight is caused by conditions. It's not just necessarily a preterm birth. Remember, we have conditions that are intrauterine growth restriction, or IUGR, which we've talked about off and on. Hypertension can come into play and be a cause of actual low birth weight. Smoking. There are other factors that can cause a baby to be a low birth weight baby. So when we're talking about predicting spontaneous preterm labor and birth, there are a few things that can come into play. One of them being fetal fibronectin, which we're going to talk about. It's a biochemical marker. It's a diagnostic test that is used for preterm labor. The glycoprotein is found in plasma and produced during the fetal life. So then what happens is you have fetal fibronectin that appears in the cervical and vaginal secretions, and this is in the early pregnancy. Then they appear again in late pregnancy. The test is performed by actually collecting a sample of fluid. They usually collect the sample from the vagina with a swab. The presence of fetal fibronectin during the late second and third trimester may be related to a placental inflammation, which is actually one of the causes of preterm labor. But one of the other things that you should know is the test is used to predict who's not going to go into preterm labor. So they kind of use the test as an opposite. So if you come in and you're presenting with signs and symptoms of preterm labor, they're going to take a swab, they're going to test the fluid, and they're going to look at the fetal fibronectin. They're going to look to see if it's negative. If it's negative, then you're unlikely going to go into preterm labor. So that's kind of how they use the test. Another thing that can be a prediction is actual cervical length. We're not going to go in too deep into talking about cervical length. That's just another factor. The fetal fibronectin is one that you are going to see. They do use this on labor and delivery in order to rule out who is not going to go into preterm labor. Some of the other things that can actually cause spontaneous preterm labor: infection, bleeding at the actual placental site. When we're talking about infection, organisms are usually found in the lower GI tract. Or, sorry, not GI. I get stuck on GI. Genital tract. They can also be in the amniotic fluid, the placenta, and the membranes. You can also end up with your UTIs and intra-abdominal infections, such as appendicitis, are common. So some of those types of infections are what would cause or put a person at higher risk for preterm labor. So when we talk in terms of prevention for preterm labor and preterm birth, we want to think about addressing the risk factors. You have on page, I believe, 442, there's two boxes, 17-1 and 17-2, that talks about some of the common causes of preterm birth and risk factors for preterm labor. So one of the examples is hypertension. So if you have a patient who has hypertension, and I'm not talking about hypertension that they developed as they were pregnant, I'm talking about pre-existing diagnosed hypertension, that puts them at risk for preterm labor. So we want to make sure that they're taken care of. We want to make sure that they're taking the appropriate blood pressure pill that they can take for being pregnant. We want to make sure that they're taking it and monitoring their blood pressures. We want preventative measurements: health promotion, disease prevention. Smoking cessation. If mom's a smoker, she's at higher risk for having a preterm birth or preterm labor, or both. So smoking cessation would be one of the things. So some of those are those types of things that, as the nurse, you're responsible for education and teaching, and that's always big and key in the nursing world. So the other things we want to do is we want to make sure that we recognize early preterm labor. So you have on page 445, there's a patient teaching box, what to do if you have preterm labor occurs. Have them empty their bladder, drink 2 to 3 glasses of water or juice. They need to lay down on their side for an hour. They're palpating their contractions because we need to know how often they are, the intensity of the contraction. And if those symptoms continue, then they need to call their healthcare provider, or they need to come into the ER, labor and delivery, depending on where they go. So you guys can review over that box. Now, of course, if they are having bleeding, fluid leaking from the vagina, or they have contractions every 10 minutes or less for an hour, they need to come straight on in. They don't need to go through and do all the empty the bladder stuff. If those are the symptoms they tell you right off the bat, they're coming in. Some other things is on box 17-3, which is on page 445, also goes over signs and symptoms of preterm labor. So what is actually defined uterine activity? What is defined as discomfort? What are they feeling? Vaginal discharge, what it looks like, or did they have rupture of their membranes? So what happens if we have this mom and they are going to have a preterm birth? There's no stopping it. It's inevitable. We want to make sure that they're transferred to a hospital that is equipped to take care of a preterm infant. We want to make sure that they get antibiotics because we want to, during labor, we want to prevent a group B strep infection in a baby. We'll talk more about group B strep and when that's tested, when mom is tested for that, and how they manage it. We also want to give glucocorticoids because we want to know that baby has nice, healthy, strapping lungs, And they can also get mag sulfate. It's given 32 weeks before. This helps reduce the incidence of cerebral palsy in the infants. We also want to educate the mother on signs and symptoms of preterm labor. So what are the three things? How do we diagnose preterm labor? How do we say that, yes, this lady is in preterm labor? One of the things is gestational age between 20 to 37 weeks. Uterine activity, contractions. We want to know if she's having contractions more than every 10 minutes that persist for an hour. We want to know, does she have progressive cervical changes? And when I'm talking cervical changes, I'm talking about effacement. That's 80%. Cervical dilation, 2 centimeters or greater. Now, if they do use the fetal fibronectin, they do a sample of the cervical and vaginal secretions. They actually test if you're doing that, because we're taking cervical and vaginal secretions, you want to make sure that you do the test before you actually do a exam, because the lubricant that they will use can actually reduce the accuracy of the test. So if you're going to do a fetal fibronectin sample, you're the labor and delivery nurse, that sample needs to be collected before you go in and do a vag exam, because labor and delivery nurses can go in and assess dilation and effacement, so they can do that. So now we want to know, what can we do? How can we help these moms? What are some of the treatments that can be used when we talk about preterm labor? So if mom is having some signs and symptoms of preterm labor, the ultimate goal is to try to hold her out closer to 40 weeks gestation than early on. So the goal is trying to manage the symptoms, monitor her, monitor baby. So it may be a fact that she's just showing a few signs and symptoms, so they're going to send her home on bed rest. They're going to limit her work depending on what kind of job she does. But we have to consider, if she's home and she's on bed rest, a couple things happen. She's at risk for a clot. She's at risk for muscle atrophy. She also has or starts to have effects physically, psychosocial, because she's in bed rest. She's maybe isolated. She's isolated to the bed in a cubby hole. She's isolated to the couch. So bed rest means that she can't get up and move around. She needs to have her stuff close to her. She needs to have some kind of activity to keep her engaged. I mean, think about being stuck on a couch. Some days that probably sounds pretty good, take a nap on the couch for like a whole day. But after several days, not so great. So that's just one thing to keep tucked away in your mind. The other thing is they actually do have to restrict sexual activity. Your book says that this really doesn't show any kind of effects on preventing preterm birth, but it's one of the restrictions they will probably put on to mom. Environment, just thinking of the home environment, she's on bed rest, like we talked about. Keeping her things close to her, a phone, puzzles, stuff to do, that kind of thing. The other thing we're going to talk about is tocolytics. So when we talk about tocolytics, they're given because they arrest the labor after uterine contractions and cervical changes have occurred. A couple of the tocolytics are listed on your screen that they give: terbutaline, indomethacin. There's another one that your textbook talks about, but they don't give it anymore. Ridodurine, they don't give that one. It's not used. So what's the protocol? What are we doing with tocolytics? So how do we care for this woman? We want to tell her the purpose of the tocolytics. We want to position her on her side because we want to enhance placental perfusion and reduce pressure on the cervix. She's going to have her vital signs monitored, lung sounds, respiratory. Baby's going to be on a monitor. We're going to also look at eyes and nose, daily weight, and mom will also be on a fluid restriction. And some of these things that I'm talking about is on page 447 from box 17-6. The other thing is, what are some contraindications? Who should not get tocolytic therapy to try to pause or cease preterm labor? Moms who are severely preeclamptic or have severe gestational hypertension. Moms who have significant vaginal bleeding and cardiac disease. Now, baby, if they are 37 weeks or more, they should not get tocolytic therapy. More than likely, they're going to let mom go ahead and labor and deliver. They should not get tocolytic therapy if it's a fetal demise, if there's any kind of anomalies. There's something called chorioamnitis that we will talk about. If mom has that infection, she should not get tocolytic therapy. So when we also talk about tocolytic therapy, so you know, tocolytics don't show that there's a reduction in preterm birth. They actually give the tocolytics because we want to delay the birth a little longer so that mom can get betamethasone or her glucocorticoids. And depending on where she is, that we're extending or holding off her delivery to get her to a place where she can deliver safely and the appropriate care for baby. Mag sulfate is also another one that can be given. It inhibits uterine contractions, and it actually will decrease your intracellular calcium levels. There are some things with mag sulfate. It has fewer serious maternal and neonate complications. There is a little medical alert box on page 447 about mag sulfate. Remember, mag sulfate decreases the central nervous system, so it is essential that the nurse is assessing deep tendon reflexes, respiratory status, level of consciousness, and that we are assessing for the signs and symptoms of toxicity. So just a few more things. In your textbook, it does medication guide. We are going to talk about some of these medications, and they are important for mother-baby because there's specific jobs that they do in mother-baby. Mag sulfate is located on that box on page 448. It tells you the actual medication, the dose, the route, the adverse effects, the nursing considerations. I'm not so hung up on the fact that you know the dose and the route, but you do need to be aware of the adverse effects of it. What is this mom going to present with? What is your responsibility as the nurse? Some of the other medicines are your terbutaline or breathine. That's a tocolytic, and there is the information on that same page. Then when you go over to page 449, it talks about your Indocin is another one that's on there, and then your calcium channel blockers, which is your nifedipine, which is one that they do use often, and it's oral. This one's given oral that they will use when mom's on antepartum. So there's some other information about the medications. So when we talk about nifedipine, we're talking about it being a calcium channel blocker. We also want to know that it inhibits the calcium from entering the smooth muscles, and it reduces the uterine contractions. That's why it's considered a tocolytic. It's rapidly absorbed. Maternal side effects are headache, flushing, dizziness, nausea, hypotension. And one of the things you need to know is they should not be giving nifedipine if they're giving mag sulfate. What happens is it causes skeletal muscle blockade. And it should also, nifedipine should not be given along with or following a beta-2 antinergic antagonist, which would be your breathine example. So let's review the medications I'll put up here for you. You have on page 448 mag sulfate. You also have breathine. Or terbutaline. And then on page 449, you also have listed your calcium channel blocker, which is nifedipine or Procardia.